Hello again. This is Earl Silverman, Editor-in-Chief of the Journal of Rheumatology, welcoming you to my interview of one of article particular interest, excuse me, from the March 2025 edition of the Journal of Rheumatology. Today, I will be speaking with Ms. Rachel Giblon and Drs. Elena Myasoedova and Cynthia Crowson, who are three of the authors of our featured article, which is titled Trends in Anxiety and Depression Among Individuals with Rheumatoid Arthritis, a Population-Based Study. And I want to thank the three of you for taking the time to speak to me and the listeners on behalf of all the authors of your paper and discuss what I feel are very interesting findings. So with that, we'll go ahead. So can you please explain what led you to look at the issue of anxiety and depressions in patients with RA?
Thanks for that question, Earl. As you may know, we have been collecting data on our rheumatoid arthritis cohort for several decades, and we know from our cohort and from others that depression has been an issue for these patients. And we also know that treatments have improved, particularly with the use of biologics. So we wanted to take a look and see whether those improvements in treatment had resulted in improvements in depression as well and anxiety.
Anything to add, anybody? Okay, well, I think you actually answered the next question. What was the aim of the study? So we'll move on. Won't be redundant. So, but if you can please review the methodology of the study, and you pick different time periods, and please explain why you picked those particular time periods.
Sure, I'll take this one. So our study used a retrospective population-based cohort design, which means we leveraged the Rochester Epidemiology Project, which is this comprehensive medical records linkage system. And we use that to identify all adults who were diagnosed with RA between 1985 and 2014, based on the 1987 American College of Rheumatology criteria in Olmsted County, Minnesota. And then for each RA case that we found, we were able to match to a comparator without RA based on age, sex, and calendar year. And then we were able to look forward and see the mental health conditions they were diagnosed with using validated ICD-9 and 10 codes. And for this study, we required at least 2 codes separated by 30 days to help enhance the diagnostic accuracy. And then each participant be followed until the end of 2020, or death or migration, whatever occurred first. And in terms of the time period, so we went with 3 decades. It was 1985 to 1994, 1995 to 2004, and 2005 to 2014. And so this was one to evenly divide the 3 decades of RA incidents into distinct intervals. So like Cindy pointed out, there may be changes in RA management, treatment strategies are evolving, maybe just broader shifts in healthcare delivery. And we wanted to be able to look at mental health outcomes over time and the influence of those things. And since we used the 1987 ACR classification criteria to define RA, we didn't want to look too far back into earlier decades because we wanted to meet the same diagnostic standards. And one of the key aims of this study was also having this really long-term trend to capture those as well. So if we ended our study in 2014 and we were able to follow up through 2020, that really allowed us to capture those longer term trends that we were trying to get at. And then in terms of like the statistical analysis of our data, we used Cox proportional hazards models. So those were used to estimate the relative risk of developing either anxiety, depression, or both conditions together over time. And we compared persons with RA to their matched non-RA comparators, but we also looked by decade and at risk factors within the RA group itself. So this would allow us to account for differences in follow-up time and censoring, like for the time to event data that we use, but still give us like a robust assessment of those long-term risks of those psychiatric disorders. And then we also adjusted for some key demographic and clinical factors when we ran our models, so like age and sex. So we wanted to isolate the independent association between RA and mental health outcomes, while accounting for some of the potential confounders. And in the same vein, we also looked at a few associations between RA and mental health outcomes and to see if those differed by age and sex. So we included some interaction terms in our models. And then finally, to complement the hazard models, we also calculated cumulative incidence of each outcome, adjusted for competing risk of death, to look at the incidence rates kind of over time as well.
Thank you. That's very extensive. Quick question though. I guess it never occurred to me before. When you use the ICD coding for presumably depression and RA, etc., I guess my question just comes down to how good is coding for, I know RA has been well validated, but for depression and anxiety, because that certainly if there depends who follows them, I would imagine. So do you have any information about that? About how good code ICD 9, 8, or 9, 10 coding is for mental health, for anxiety and depression?
We don't have like a positive predictive value for this definition. It's a great question, Earl, because we do know that there's probably some undercounting. At the same time, there's a lot more screening for depression, happening now, and actually that could influence our time trends, right? Because if there wasn't as much screening, 2 decades ago, that could make a difference, right, in the accuracy. So hopefully these things are coming to medical attention, more nowadays than they have in the past, as hopefully some of the stigma with mental health is being reduced in recent times. But it's possible that we are undercounting, for sure.
Well, so that leads up perfectly to the major findings, and then you can try to explain after what you said, potential causes. But so what were the major findings of the paper?
Yeah, so interestingly, kind of, I guess in contrast to what Cindy is saying, is we did find that there's an increasing incidence of anxiety over time. So we found that individuals diagnosed with RA in more recent decades, like specifically between 2005 and 2014, had significantly higher rates of anxiety compared to those diagnosed in earlier decades. And so although we actually did not find RA status itself to be a significant risk factor for new diagnoses, patients with RA did have this progressively increasing risk of receiving a new diagnosis of anxiety over time. And you can really see this with like the 10-year cumulative incidence of anxiety. So that rose from 6% in the 1985 to 1994 cohort up to 16.6% in the 2005 to 2014 cohort. And this increase was most pronounced among the seropositive RA patients. And actually, in contrast to this, the depression rates were relatively stable over time in both the RA and non-RA groups. So we didn't really see significant differences in risk there. And kind of like conversely to the anxiety, one interesting finding we saw was that the seronegative RA individuals in this group diagnosed in the most recent decade, so that's that 2005 to 2014 decade, were actually less likely to develop depression compared to those diagnosed in earlier periods. And then for the co-occurring anxiety and depression, we again saw this rising trend over time. So persons diagnosed with RA in 2005 to 2014 were having a higher cumulative incidence compared to those diagnosed in earlier decades. And again, even though RA status was not a significant risk factor, we did see like a 1.5-fold increase of developing both conditions for that RA group. And we also saw that within the RA group, this increase was most significant among those seropositive patients. But in terms of the interactions that we had looked at between RA status and age and sex, we didn't see that any of those factors modified the observed differences in this study.
Thank you. Want to add anything? Okay. So having heard that, so what do you believe the implications for patient care are, as we know?
I can take this one.
Okay.
For stating this question, it's really interesting that we observed rising trends in anxiety and co-occurring anxiety and depression, and that in part may signify already increasing awareness and screening for these conditions, but also there may be other underlying reasons. And so these practices should probably continue and continue to become this becoming standard part of RA care in terms of identifying people with depression, anxiety, and coexistent depression and anxiety. And that can be done through use of variety of screening tools, including the PHQ-9 questionnaires, 9 or 8, generalized anxiety disorder questionnaires such as GAD-7, as well as PROMIS measures that are part of EPIC and so can be conveniently used for this purpose. And then what to do next is to integrate this information into care for patients with rheumatoid arthritis and make connection with primary care providers as well as with mental health professionals to develop more holistic treatment approaches to these patients, and that can be through pharmacological interventions, as well as psychosocial interventions, as well as just interventions through physical exercise, and so on. So really, in each patient case, it would be helpful to identify what particular stressors and factors are associated with their conditions of depression and anxiety, if such were found, and then try to target that more into personalized treatment plans for avoiding that can be financial issue, maybe even around the medication, insurance problems, some social issues, as well as health issues, and so on. So identifying some personal factors associated with these conditions are important and can be helpful. And then educating patients and making them aware of the risk and increased risk of these conditions associated with rheumatoid arthritis, as well as linking that the presence of depression or anxiety to potential adverse outcomes of the disease. And there's probably bidirectional relationship there, but patients may benefit from being aware about that. And then finally, addressing barriers to mental health care. So making sure that patients know about where to go, what are the channels for them to use if they are diagnosed with this condition or screened positive for this condition.
Thank you. Very, very interesting. So what struck me was as outcome has improved with the advent of really blockbuster drugs, it is fascinating that there is more anxiety and depression being found. Certainly, it's intriguing to me that it's not intuitively obvious unless there's an awareness or something, other factor we're missing. Any guesses? Any comments?
There's also, I think we've seen increased rates of and increased ratings of pain, and potentially difficulty with doing ADLs, and that partially implies possibly high expectations from patients in terms of their performance on a daily basis. And that relates to different outcomes that may be subjective outcomes, and so patients are not anymore satisfied with the level of pain as they were perhaps a few decades later. There can be other explanations too, but that's one of the explanations that I thought about.
Yeah, it'd be fascinating just to look at the causes. And I try to explore more, and because it gets to the next question, to improve the care. I mean, as we are improving what physicians look at, structural damage, et cetera, we're failing in other things. So I think the point of trying to look at other factors may lead to this, might improve care.
I think it would be great to have interventional studies specifically looking at the effectiveness of integrated mental health interventions in RA management, and leading that possibly to evidence-based treatment guidelines on management of these conditions, as well as looking at metrics of mental health in patients treated with different regimens of among rheumatoid arthritis treatments, which is not always included as outcomes of the clinical trial. So that would substantially inform and improve evidence-based medicine around rheumatoid arthritis in general, but also in terms of this mental health outcome issue.
Thank you. Is there anything you'd like to add that maybe we missed discussing?
We kind of touched on it a little bit, but we did see increases, in anxiety and depression in the comparators, those without RA, over this time period. And so there are some other drivers going on here, that may be more than just increased awareness as well. There may be societal changes, and our study, pretty much stopped before the pandemic, but we do know that there are some increases in anxiety and possibly depression, since the pandemic, which hopefully are going to be handled and resolved now. But we do need to, it's important for us to look back at this time trend analysis again, and add another decade when we can, to see what may be happening in the most recent years.
Just for my and maybe the audience's edification, just when you looked at the decades and the diagnoses of anxiety and depression, was it during that 10-year period or ever? So if somebody was diagnosed in 1990, did you take it if they were still alive up to today or whenever the study was over?
Yeah, we considered it to be a chronic condition. So we looked at, the first time they were diagnosed with anxiety or depression, and that in our estimates of cumulative incidence, that's really anyone who's ever had that diagnosis.
Okay.
And so hopefully many of them have received treatment and are doing better.
Right, that's the next thing. Well, okay, anything else you want to add? Okay, well, in that case, I want to thank you for taking the time. Very interesting findings, and I appreciate the insight you brought to your paper. And to our viewers and listeners, please read the complete article titled Trends in Anxiety and Depression Among Individuals with Rheumatoid Arthritis, a Population-Based Study. This article can be found by scanning the QR code of the interview in order to read the article. It's on our website. There's also an accompanying editorial, I suggest interesting reading, called Mind Matters in Rheumatoid Arthritis, The Rising Burden of Anxiety and Depression by Dr. Sweet, Wang, and Bartels from the University of Wisconsin-Madison, USA. Both the original article and the editorial are available online at our website and in the print edition of the journal. And I want to thank you for joining us. And please come back next month when I will again interview the authors of an article of particular interest that I've selected from the April 2025 edition of the Journal of Rheumatology. And I'd love to hear any comments on X at jroom or by email at manuscripts@journalofrheumatology.com. And again, thank you, and the audience.
Thank you.
Thank you.